Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
So once again, good evening, everybody, and we're going to start with our class. Actually, today I'm just giving you a little orientation as to what kind of questions can be asked in your exam and how to deal with these questions if you know either very little or nothing about that particular topic. So I have taken two such examples which were asked recently in the DNB, this NB diploma exam, and earlier on, the recent advances questions that were asked were somehow, from some of your latest journals or, the articles which keep coming. But this time, specific such articles have come, which I looked up. They are, very integral part of the TOG articles. TOG articles, actually, this is obstetrician and gynecologist. This is a journal by the European journal by the College of the Royal College, and it's got a lot of beautiful articles. And the beauty about this TOG articles is that it's in a very structured format, exactly the way you would love to write in your exam. You must have gone through the TOG article, and you must have gone through, the pattern of a TOG article, and it's very beautifully, scripted, beautifully written, to the point thing is there, but obviously it is lengthy. So I'm going to be including, like I promised, this as well in my recent advances, because that gave me an insight as to, this will be an easier, one step better for you to be prepared for the paper number 4, which is the most dreaded for all of you, because the questions that are asked, sometimes they are, way out of your league. I mean, even things like this, accessory cavitated uterine malformation, is, if you think about it, it becomes easier, but it's not very simple to, crack and write down about this point-wise. So, and not only am I going to give you an insight as to how to write an answer on this particular important topic, but I'm also going to give you an insight as to how to manage such kind of questions which are way out of your syllabus. Okay, so this is actually a consultant level question. Actually, we've read the main, we know the main, and now we're researching something which can also be seen once in a while in some clinic, but that's not a topic for postgraduates to be asked. Anyways, this is DNB, and we expect such things from DNB. So give me just maybe half an hour to 40 minutes tonight, and you'll be through two very important questions. Not only that, a very important thing is the insight as to writing down difficult questions. Number one tip, whenever such a question comes to you in the exam, which you know nothing about, do one very important thing, just leave it towards the end. Okay, so just in case you are not able to write down anything, or because of the dearth of time, you're not able to touch that topic also, at least you have this thing in your mind that, well, I couldn't have done much anyways. Okay, beating about your head for an answer which you really don't know, and even if you do write, you'll get maybe 1 mark or 2 mark, does not, define you. And that stupidity should not be done. Okay, instead of that, write down and attempt those questions which you know very well, and just leave a page or 2 pages for that answer and move ahead. This is what I did when I also had my DNB paper. I was pretty proud of the way I did my theory exam. It's a lot to say like that, but in all humility, that there's some moments in your life when you feel that I seized the day. That was one of those times. After coming back from my theory exam, I felt I did a good job according to my preparation, but the way I wrote the answer paper was decent enough from my side. So I also had encounter of such questions which were not prepared well by me, but I gave them the justified amount of time. And every question, the question itself speaks to you. Like, for example, this accessory cavitated uterine malformation. You know that it is not related to the uterus, it's somewhere in an accessory appendage. It is a uterine malformation. By the name only you know. And it is also cavitated. That means it's not just a complete, muscular bundle somewhere. It also has a cavity inside it. But obviously, you cannot go any further. And this is one I've given you in the heading, and unfamiliar cause of dysmenorrhea, but all that it can cause. So if it's aligned with myometrium and it has endometrium inside, it becomes something like an endometrioma. But it's not exactly, because it also has a myometrial core. So you are getting some hints, beat about the bush. That's all I'm saying. You have to, usually you get a question, a short note of 5 marks, right? You can easily fetch 2 to 3 marks. That you will even fetch in a question you've written absolutely all right. So the question is that how to distribute your time wisely. Instead of not attempting any questions, always good to write down at least some points, and you might fetch at least 1 or 2 marks, which is almost similar to fetching 3 or 4 marks. Okay, so you're behind from your colleagues only by 1 or 2 marks. That's what I'm trying to say. And the other topic which I'm going to discuss today will be ERAS. Actually, it is enhanced recovery after surgery. But and this question has been asked before, so you are not totally zapped by this kind of question. So I'm going to be taking that as well. Now, enhanced recovery after surgery, it itself says a lot. So just give me a couple of minutes tonight, guys. I will not take a long lecture. I'll take a very short, crisp, and beautiful lecture so that these two topics, if at all they come in your exam, you do not even have to revise. My lecture, my talk right now is going to be there in your mind till the end. You will not forget these two topics, okay? So let's start with accessory cavitated uterine malformation. Like I said, I gave you the hint what exactly it is. So here it is the pictorial, memory. This was there. It's all made from the TOG article. So I've just taken important points from it and made this into a small lecture for you to understand. So I call them ACUM. So they are basically isolated. See, you can see this cavitated lesions. Where are they located is important. Located within the lateral aspect of the myometrium, inferior to the attachment of round ligament of the uterus. If you write this thing, you've got the marks. You've got the marks, because this is very important. People will understand ACUM. Anybody can, say this, that it's a cavitated lesion and it is a uterine malformation. But if you write down this specific thing, that is lateral to the uterus and probably there in the myometrium, in the broad ligament, and attached to, it's below the attachment of the round ligament. So the specific site is below the attachment of the round ligament. So here you make a rough diagram, make the two round ligaments. As you can see, this is the fallopian tube, this is the broad ligament, and here is where you find your ACUM. This is the location. So basically, it's a cavitated lesion, functional, with containing what? Functional endometrium surrounded by myometrial mantle. So you can understand yourself that this over here is the myometrium around. It's just like a small uterus over here. A small uterus, I said. Now, whenever I say there is a small uterus over here, don't you think what becomes very important? Can anybody quickly tell me what becomes very important for me? What am I thinking of? Another uterus. Any differential diagnosis that you would want to know? Anybody? Any specific diagnosis that comes into your mind, or a differential diagnosis that comes into your mind? If you answer this, you are passing DNB anyways, because you're already prepared. Okay, these small things, they tell a lot about your preparation. How well are you able to understand what examiner wants out of you, correct? So I'm thinking about a uterus. For those who missed the question, I'm saying there's another small uterus over here. So what thing is very important for me to know over here? Usha has answered it correctly. I knew it. She'll answer it. I'm very, very proud of her. And she's right that this means that what is important from my point of view as a consultant or as an examiner or a gynecologist for treating doctor is very important, is that whether it is a horn which is communicating with the uterus, it is attached to the uterus, it's a kind of uniconnuate uterus, or a biconnuate uterus with a rudimentary horn. What is exactly it is? Okay, is it a rudimentary horn, or is it actually having some connection or no connection at all? That is very important for me, because just in case it has any connection with the uterus, it can be what? Now, this is the second question. If it's got any connection with the uterus, what can happen? What can happen? Come on, guys. What is a possibility? I need an answer. All of you will, because this will emboss in your mind, guys. If you listen and answer right now, I don't think you'll have to. Yes, excellent. It can be associated with pregnancy. Ectopic, non-ectopic, whatever. Obviously, it's not at the right place. You can call it an ectopic pregnancy. But yes, if it's communicating with the uterus, you guys already know it. You guys already know. You don't need this lecture at all. So it will be associated with the pregnancy. And that is our main concern, correct? So this is the gist about what exactly it is. And now as far as etiology is concerned, most probably the precise origin we do not know, but they all agree, all authors, they agree, even you will agree, that there are some kind of Mullerian duct abnormality. Mullerian duct abnormality, I'm very happy and proud the way I've taken my classes on Mullerian duct and abnormalities, because first of all, I went through a lot of lecture on embryology, made your, footing very strong with embryology, and then I took up the Mullerian abnormalities. So all of you who missed it, please at least take my live class recording folder and watch it, because that kind of embryology, I bet you will not be able to find anywhere. In no lecture in your academic institutes, and in no lecture on the YouTube. You'll not be able to find. Very lengthy lectures are there, but not for your, at your level. The things that you just need to know as a gynecologist, everything is there. All right. So clinical presentation. What do you think would be a clinical presentation? Think about it yourself. Since a myometrium is there and endometrium is there, what's going to happen? Severe dysmenorrhea. Severe. Patients going to come with a lot of, severe dysmenorrhea, commonest presenting symptoms. See, it's the commonest presenting symptom with ACUMs. Pain can be central, it could be ipsilateral, and pain is thought to be, obviously, because it is a menstruation going on and it's an enclosed space. This is what it is. Something like endometrioma, but even worse because it's got myometrium. See, when endometrioma has a lot of inflammation or, a lot of, this blood collects, it has at least some where to stretch a little. Okay, this doesn't even have anywhere to go. It's like a very thick myometrium surrounding it, and everything that is accumulating in it, severe dysmenorrhea. So obviously, what is the investigation of choice in the first line imaging tool? Obviously, our very own, very favorite, the TVS. Correct? Particularly important. And what will you find in it? Ground glass. See, this is also like an endometrioma. Right? Contents being fluid should be avascular and Doppler examination. The blood flow in the myometrial mantle should be no different. They can be mistaken for obstructed congenital uterine malformation. So here is where my next modality is going to help us, and I'll just quickly go on this. So what did I say? Obstructed, non-obstructed. How will you get to know? You'll get to know through HSG. So if you can see a mass right beside the uterus, which is exactly like the uterus, you would want to know whether it is a uniconvate, biconvate, rudimentary horn. What is it? How will you know whether it is communicating or not, whether it has a channel to get out or not? It is through your HSG. So otherwise HSG is of no use, but to confirm a normal uterine cavity, it becomes important. And this is where, see, it confirms a normal uterine cavity and a fallopian tube. So at least uterus and fallopian tubes are fine or not, or they also have some ambiguity. One fallopian tube is communicating with that horn, and one fallopian tube is communicating with the uterus, the main uterine cavity. And even the uterine cavity is like more or less looking like a uniconvate uterus, and this is a rudimentary horn, but rudimentary horn, associated with the ACUM. It's possible. Everything is possible. In fact, the latest recommendation, the latest the difference that I taught to you about the different classification systems that we have, the latest classification, it has the 6th variety is all atypical uterine malformations. Earlier on it was very specific. You have this class 1, class 2, and now you have the 6th class, which says atypical uterine malformations, right? So this will become all these which are not included in anything will come under those atypical uterine malformations. And of course, MRI is the gold standard when you're deciding for congenital uterine malformations, not ultrasound. Ultrasound is the first line. Remember that. Ultrasound is the first line diagnostic modality when you're talking about uterus and anything to do with the uterus, pathology that you have to delineate because of any problem that the patient is coming up to you, symptoms, signs, whatever the patient is coming up to you, the first thing you do is to take her up for an ultrasound, because it is rapidly available, it is painless, it is non-invasive, and it is cheap above all. Plus expertise of ultrasound you get everywhere. Okay, MRI machine is very heavy. The MRI setup, not everywhere do you have, you do not have technical staff to support, you do not have the maintenance of the machine very easy, and you do not have, and it's very expensive. So you do not refer every patient for MRI, but you do refer every patient for ultrasound the moment patient comes up to you with any sign and symptom, isn't it? But MRI, all that being said, MRI is the gold standard when it comes to talking about uterine malformation. And sometimes in certain cases, it's not even very evident in MRI because it's such a rare entity. It is difficult to understand. What they write down in MRI is very different than what actually I'm teaching you right now. They will write down in MRI, T1 weighted images show this is, T2 weighted images show this. This looks like a possibility of a myometrial course around with a stroma of endometrial fluid inside. What do you expect of it? Then they'll say query endometrial cyst, then they'll say query uterine malformation, query ovarian, not exactly ovarian, but some mass, query some mass. So it is very difficult to name it as an ACUM the moment an MRI report. MRI report is very different from, they will not write down this diagnosed as accessory cavity uterine malformation. That's your clinical acumen, that what do you perceive of it. They will just tell you what they're seeing. They're seeing a myometrial core, and they're seeing some fluid inside it. Looks like a cavitated malformation beside the uterus. Even that is not going to be written in the MRI. So this is what I'm trying to say. See, here you have T1, T2 signal enhancements, which is similar to that of junctional zone. That is what they're going to write down. Exactly. A central cavity surrounded by a well-defined ring, and T1, T2 enhanced single enhancements, looks like a junctional zone. Now you keep thinking what can be. See, surrounding cyst wall or myometrial mantle is seen, thickened, hypointense tissue T2. This is exactly the report is going to be. Do not think that is going to be this kind of report. It's an ACUM. But still, whenever there is a uterine malformation, you always cross-check it with MRI, right? Then comes the management part, or maybe a one step before that. Suppose you're not able to understand from MRI, the other option is laparoscopy, a diagnostic laparoscopy, followed by an operative if required. So you can easily convince a patient to, talking to the patient, telling them that, we need an invasive method to diagnose your situation, your condition. You cannot convince them. Even I'll not be convinced. Obviously, putting me under anesthesia, putting a laparoscope inside me just to find out what is wrong with me. No, but if I say that you'll be treated in the same go, then they might get interested. Okay. So, well, this is what my next slides are going to be, and I'm going to just give you a little, maybe 2-3 slides I'm discussing right now, that this is what is going to happen. So there are documented cases of these ACUMs undergoing numerous diagnostic laparoscopies. Even if they're going through diagnostic laparoscopies, and then nobody's coming down to this conclusion, because what they see is in laparoscopy that this broad ligament, it's a little swollen. Once you open the broad ligament, only then you'll be able to see the cavitated malformation, right? And even then, it will not be very easy to diagnose that it is that, because the entity is so rare. It's not easy to find out. And by the way, it's looking very different from this slide. See, this is how it looks from front. But when you're looking in the pelvis, you're looking from above. So what you'll see is basically the tube, the round ligament, and everything seems all right. And fallopian tube, by the way, fallopian tube, when it goes down and has these two curtains of broad ligament, it's like a curtain, and something is inside the two sheath, the two curtains. All right, something is developing inside these two curtains. So it's very difficult, to find out whether actually you'll see, oh, everything seems all right. Uterine tubes, let's do the lap and diet test. She's fine. There is no problem. Uterus seems okay. Both the ovaries are fine. And sometimes broad ligament, this cavitated malformations get missed. This is what I'm trying to say from here. There are documented cases where even numerous diagnostic laparoscopies have failed to investigate failed to diagnose the ACUM. So here what will help is an intra-op ultrasound examination. Now you're combining two modalities. All right. So intra-op ultrasound examination to locate the ACUM and aid in the excision. And once you do that, you see that microscopically it is actually uterus-like organization. Central cavity is lined by endometrium, and myometrium surrounds them. And by now you've ratified these two sentences, okay? And here you can have estrogen receptors positive, progesterone receptors. They are all indicative of, you want to be sure that, you have these endometrium only. It looks like, and it is actually that. So you have estrogen, progesterone receptors, which are all indicative of endometrium. And here I would like to ask you the differential diagnosis, which many of you already haven't taken a peek on. So let me know, what do you think when a patient comes to you, she's having this kind of mass, all right? What other things will come into your mind when she comes to you with dysmenorrhea and suspected mass in one of the lateral appendages, let's say, because that's all ultrasound is going to tell you. So give me quickly the differential diagnosis that will come into your mind: severe dysmenorrhea, pain, abdomen, and this, right abdominal mass. I think endometrioma definitely will be my first and most characteristic DD, because that's what it looks like. Ground glass appearance, it shows. Cyclical dysmenorrhea, she's going to specifically tell you about, okay? Or dysmenorrhea, it's a cyclical pain, I'm sorry. Dysmenorrhea, obviously. Yes, adenomyosis, of course. You can say adenomyosis, but adenomyosis is like, one big. Remember, when I spoke to you regarding adenomyosis, I told you very specific symptoms now, very specific endometrial criteria have become of that of which diagnose adenomyosis, which is the thickened this thing, junctional zone, and this lakes inside the endometrial cavity, and striations, and these are very specific ultrasound criteria which you should know of adenomyosis, especially because it's latest. Yes, but yes, it will come under the DD because that also causes dysmenorrhea. Broad ligament fibroid, excellent. I'll give full marks. This sunflower, whosoever this sunflower is, I'm very, very impressed with both. And this star. Some people don't want their names to be taken, I guess, but I'm very impressed. Broad ligament fibroid. I think it was not even there in the, it's not even there in the DD, but I was thinking it right from the time it came. I am so thoroughly impressed. You guys do not need anybody. You are sufficient in yourself. Very good. I'm very, very proud. So yes, broad ligament fibroid is another very important DD, except for the fact, of course, it will not have a cavitated lesion, but you know what? You can always think of a broad ligament fibroid degenerated. That's how it looks. Yes. And that can cause severe dysmenorrhea as well. Very good. So you do not need my DD because you've given a better DD than me. Excellent, guys. Excellent. So we think about managing such a case. Now just imagine what could be the management of a case with severe dysmenorrhea, but a lesion along with it. So you have some functional lesion as well. You have some structure on which you can put your hand, oh, this is the one which is causing you dysmenorrhea. So obviously the actual management, the real management is surgery. It is surgical, correct? But that does not mean that we will not give her an expectant management. Okay, whenever a patient comes to you, she's not immediately ready for a surgery. So she's going to buy some time. And in that time, what will you give? You'll give her painkillers. You'll ask her to maybe go through further investigations to be sure what we're dealing with over here. We'll see whether she's observed, and we'll observe whether it's increasing with time, whether the symptoms remain the same, whether the symptoms abate with just medicine alone. If she's a female who cannot currently undergo surgery, at least for a year to come, then in that case we have nothing but to do. See, expectant basically means that you're doing nothing; you're just observing it, right? Expectant management means that we're just observing it most of the time. Medical management is the one in which you give her something, not exactly very high flow medicines for a longer duration of time, but yes, medical management means you're giving her some drugs. Surgical, of course, means surgical. So here we basically we're seeing the natural history. We're observing how it grows, whether it grows or not, whether it remains the same, whether it's decreasing with time. Maybe if she's around menopause, it never is a problem later on. She's undergoing menopause and it never has a problem later on. If she insists still to take out, no problem. And here comes the medical management. So you have the NSAIDs over here. They can help you, of course. They are over-the-counter drugs. The first drug that anybody gives to any patient who comes with any kind of pain, NSAIDs are given. Then, of course, you have so many things like OCPs, Mirena, gonadotropin-releasing hormone. Can you tell me if Mirena is going to work here or not? Is Mirena going to work here? Is it local releasing? Does it go in the bloodstream? Is it going to reach? Is it going to reach this place? It's just a question that I just thought I'll ask you. Whether Mirena is going to be helpful over here. It'll help. It'll help because what it does is basically it definitely has a local action which is very, very powerful. Nowadays, it is the drug of choice for HMB, heavy menstrual bleeding. They say it's at par with, instead of giving COCPs or NSAIDs, try Mirena first. And even to nulli gravida, they say they're coming to you with heavy menstrual bleeding, try Mirena. And no matter how bad it is in the first 3 to 6 months, it is the best thing that you can do to a patient, especially the ones who've got very irritating heavy menstrual bleeding. Is the first line according to the RCOG, NICE guidelines. Okay. Yes, it enters the circulation. Very good, Usha, and it provides sufficient, hormonal content to cause shrinkage of endometrium wherever it is. Okay, so yes, it's a drug of choice. Drug of choice. It's one of the medical managements. This we'll come back to later, or maybe this is another important question that can be asked in your exam. Now, since we know that people see, once a question comes in DNB people also know that everybody is going to learn about it. So they ask you the next question based on that first question that they asked you, which is why the DNB pattern is such that they do not repeat the same questions many times. Okay, they have a different pattern of putting their exams up. Very few questions are repeated. Topics are repeated a lot. Exact questions, they're not repeated that often. Anyway, so differences between ACUM and true cystic adenomyomas. See, adenomyoma, once it gets cystic, it's something similar to a broad ligament, a fibroid having a degeneration, something like that. Okay. So the difference between them is that this is in the younger population mostly, this is in the older. Lalipares are mostly affected, multipares are mostly affected. They both have, painful periods, but obviously this got menstrual pain is more as compared to heavy periods. Here you have both. Pain is also there, periods are also heavy. These are usually isolated lesions, and you know how adenomyosis is. Okay, they are usually found along with adenomyosis. So there is adenomyosis mostly, and then cavitated lesions are also there. Cystic lesions are there. Macroscopically, this looks like there's a distinct border between myometrium and the ACUM. Here, it is irregularly, poorly defined borders because it's almost inside the adenomyomas or an adenomatic uterus. I'll tell you about it further when probably I'll talk to you next, but I'll probably get you a picture or something about it, then you'll be able to understand better. Or do one thing, just research more on this topic because there's a possibility of it being asked next. True cystic adenomyoma. Okay, just try to learn about it and we'll discuss it in the next class. Now, microscopic histopathology, this looks like a concentric, you've heard it, you just know about it. It's a concentric organization of a smooth muscle around a cavity, and you have this endometrial glands and stroma to line the cavity. And this basically, it lacks the organization. Okay, there is no such myometrium organization. It's just interspersed, cystic lesions. Absence of an internal epithelial lining. This is not specific of, an endometrial lining is there inside a core. This is nothing like that. They're just interspersed lesions in the myometrium. This is lateral myometrium, inferior to the insertion of round ligament I just spoke to you. This is variable location within the myometrium of the uterus, often within or continuous to the endometrial myometrial junction. So it's something exactly similar to adenomyosis, but instead of being, those adenomyotic lesions, they are cystic lesions, cavitated lesions. Okay, so it's very much inside the uterus. That is very important. Okay, then there is something called as sclerotherapy. These are actually minimally invasive techniques. So they are invasive, definitely invasive. So nowadays, the emphasis is more on in-between therapies. They are neither very aggressive like a surgery, they're not very submissive like medical therapy. They're somewhere in between. So when we studied about fibroids, you know how important this uterine artery embolization has become these days on so many exams. And not just, has become important, has been important from a really long time because it's being researched a lot, especially in the foreign land. In India, not so much, because in India, surgery always takes priority over these minimally invasive techniques, because thankfully this litigation is far less in our countries. It's much more in Western world. Small things, they start suing the doctors, and they're very scared of taking a patient up for a major surgery like myomectomy, hysterectomy. They are very brutal surgeries, and it's very easy to commit any kind of a problem in the patient. And patients over there, they are so specific to even the smallest problem that they develop post surgery. So if they're having any nerve pain, or if they're having, even, swelling, edema, or, deranged, let's say LFTs or KFT, they all blame it on the surgery, and then after the life of the surgeon. So mostly the surgeons out of India, and especially the European nations, they're very scared of taking a patient up for a major surgery under a lot of, compulsive symptoms, or a lot of emphasis from the patient. They take up a patient for difficult surgeries, otherwise they usually avoid them. So they keep taking out these small, minimally invasive approaches just to keep satisfying the patient, we're doing something, we're doing something, we're doing something. But finally, the resort to all these answers, instead of so much of harassment to the patient, usually is a big surgery, which is thankfully not a problem in India, because here surgeons are still bold. It is still an open and invasive field, and patients are pretty tolerant to most of the things. In certain things, you have to take with a sip of, gulp with a sip of bitter salt, that every surgery cannot be picture perfect, because it depends upon your situation as well, and your body structure as well, your situation as well. Some patients are easy healers, some patients are very difficult healers. No matter the same person with a similar track record of successful surgeries has done the surgery in those two patients, even your mental makeup, a lot of things go in healing a patient from before to after. Your own willpower, your own, frame of mind, and of course your body habitus. Patient is diabetic already, anemic already, not very well controlled post-op. She's going to have a long recovery with maybe a lot of comorbidities. But a patient who was healthy before with a strong frame of mind is going to, develop very easy, cool post-op. So a lot of things. Anyways, coming back to the topic, what I'm trying to say is that, so these are nowadays what's happening is every surgical treatment that you study, it is preceded with a lot of other treatments. One of them is expectant treatment, one of them is medical treatment, one is minimally invasive treatment, and then comes the final surgery. So let me tell you here as well, the final resort is surgery, surgical excision. There's a big slide which I'm going to talk to you about, because that is the final resort. So all these things you're going to try or not try before you finally encourage her for a surgery. So when a patient usually comes in my OPD and she has a big fibroid, I'm very honest in telling her that final resort for you is I'll do that. And in fact, this lecture which I'm taking, I'm recording it. So do not worry. It will be posted on the portal, the same portal that on which you're watching this this lecture of mine. In the same portal, you will get this entire recorded lecture, so you will miss nothing. Don't worry. Okay, so coming back, sclerotherapy is actually, that you try to shrink something, okay, with a sclerotherapy. Similar thing is this. Now, can you imagine shrinking a myometrium along with an endometrium with this sclerotherapy alone? It's a functional thing. It's a functional. You're trying to make the tissue go dead, but at the same time, you do not know how much tissue you're making dead by this, right? So that is a problem. So alcoholic sclerotherapy can be an alternative to surgery, but again, not much research is there. It's a newer thing. Not many patients go for it, and I don't advise it. Transvaginal sclerotherapy. So coming back to the most important aspect in which you will treat it, non-surgical treatments are important in the treatment of symptoms, okay, but not because they are the final treatment modalities of choice. So finally, what we have is this. Most published cases of ACUMs that we have collected so far, they're all treated surgically, and that too with very high success rate. Just imagine just removing it from there. Okay, if it's not too deep seated and if it's not too deep in the pelvis, it's a very easy removal. Okay, if it's too deep seated, they will have to be very cautious of what? Of what, guys? If it is deep seated in the pelvis, what will you be cautious of? You people have been hearing all my lectures right from the beginning. Okay, and you've seen my anatomy lectures as well. I am not going to pardon you if you're not able to answer this question. Okay, so please tell me if it's a deep seated. Yes, correct. Most important ureter. See, once, as far as uterine artery is concerned, I'm not so scared. You know why? Why am I not scared, or anybody is not scared of uterine artery that much? Why are we more scared of ureter? Correct. I got it. You guys know it. You people are masters of anatomy. But tell me, why am I not so scared of uterine artery? I'm more scared of ureter. Reason? Yes. In a way, you're understanding. I'm pretty sure you know it already. Ureter is silent. Anything that is silent will show its colors much later after the surgery, when the patient has gone home, and will be sued for negligence. So we are trapped when a patient has gone home and a problem has happened. That time she's going to tell that I was neglected. And we'll be sued, and probably they'll win the case. Because if anything is recognized in the in the OT, that is the best. Post OT in the hospital premises, again, not so bad, not so good, but still okay. But if the patient was left to go home and the complication developed after that, you have a very high chances of being sued and losing the case. Okay. So very good, very, very good. Star, 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 another star. Ligation, it goes unnoticed, and you can ligate it, you can burn it, you can cauter, you can do anything, because you're trying to take out a very heavy mass, a myometrial mass from on top of it, right? There's a very good chance there's going to be bleeding, there's going to be dissection and bleeding, and then you'll try to take a bite, and you might end up suturing the ureter or burning the ureter, or just cutting the ureter. Anything can happen. It's a very, very dangerous and a very silent structure. It takes revenge later on. Okay, so whatever insult you do to it, it takes the revenge at the right time, and you are sued for life. So please be very, very careful. Anyways, this is just for out of light, because how much are you going to be thrown to have an ACUM in your life? How often will you be able to do the surgery if you're really lucky, or witness the surgery, and how often will you probably be damaging one? But if there is an ACUM, there is a very great possibility of damaging the ureter. And there is no hard and fast rule. I was freshly appointed as a consultant in one of the corporate hospitals, and I think the third and fourth case that I saw there was a cesarean scar ectopic. I had never done this before. I had never seen it before. And I was about to, do an operative procedure on a patient who was having a cesarean scar ectopic. And no matter how much you read from the book, it never prepares you for the real surgery. Thankfully, the surgery went on beautifully well. And we got to know that it was not, the cesarean scar ectopic growing inside the uterus. It was a cesarean scar ectopic outside the uterus. So it was even, easy to manage it. She did not bleed so much. It was a beautiful surgery, and it was a inaugural surgery for more surgeries to come, in which God prepared me for a tougher surgery of the thing. So anytime you call can also be any day, one of you attending my class can also be thrown into this kind of a ACUM in your life, and I'm sure you're going to rock it with so much of thought process behind it. Now you can write down more than a short note. You can write down a 10-mark answer and even bigger on this. So anyways, so what do? We excise the ACUM. Okay, hysterectomy, why would we do hysterectomy? We'll just excise the ACUM and be surgical, surgical removal of the ACUM. So what else? Obviously you'll have to, now, since one very important thing is, guys, do you realize the fact that I just spoke to you, that it is behind the curtain? It's behind these two flaps of the broad ligament. So obviously, do you see this? Dividing the round ligament is a proposed means to clearly identify the ascending branch of uterine artery, to reduce the risk of inversion, forget about that, to decide the planes. So if you've seen my lectures on hysterectomy, I've shown you how beautifully the two leaves of broad ligament is separate when you cut the round ligament. So it's a beautiful way of going inside the peritoneum to understand, to dissect away the ureter, to understand where the internal iliac crosses over and how the ureter crosses over it to finally go and go past the uterus to the bladder. This is how the internal iliac shifts and becomes, and gives supply to the uterus and so many other things. I told you, remember, I have made a lecture on internal iliac artery and its supply, the posterior division, the anterior division. So, and when it goes like this, the ureter also crosses over it and finally goes inside the tunnel to provide the bladder. So it cuts at right angles, actually like this. Water under the bridge. So it goes like this. From the internal iliac artery, of course, the uterine, it becomes a branch of, uterine artery is a branch of the internal iliac, right? So ureter is very close at right angles, and it goes to the ureteric tunnel and finally supplies obviously enters the bladder. So how to reach this place? How to reach this place is by dividing the round ligaments and going in, opening up the two flaps of broad ligament and then reaching the cavitated malformation and simply excising it. There is no such follow-up because it's not cancer that's going to keep developing. But of course, you can call her once, maybe once a year after that, once you've done the surgery, to see how she's doing and just go in for an ultrasound. So this is nothing but a short, a summary, you can say, a summary of what we had taught. I mean, what we've learned in this entire session and what I wanted to teach you. That's all about this slide.